everybody. Thank you for joining us at DGHI's final Think Global webinar for the fall semester. I'm Simi Ariely, the faculty liaison for DGHI's local engagement, and it's my pleasure to help moderate this discussion. Our topic today is on global and local engagement. Global health researchers and trainees at Duke and other places often work in multiple locations and have a commitment to building sustainable, mutually beneficial partnerships. As a Global Health Institute, we clearly care about health disparities wherever they occur, including our local neighborhoods, especially as we know that US continues to fare lower than many other high-income countries on significant health indicators. But there are important questions around what ethical engagement looks like and what role global health should have in working alongside existing community and public health efforts. In today's event, we hope to explore some of these issues and the ways global health perspectives can benefit from local health-focused research and education, and to get thoughts around how we can work more collaboratively in our local communities here in North Carolina to build partnerships that promote effective multidirectional learning. In today's webinar, first we'll hear from Dr. Jonathan Sugarman, who will provide some context about the local and global movement his experiences with communities have in the Seattle area. We'll follow Dr. Sugarman's talk with a panel discussion focused on perspectives from community leaders and academics to explore some of the questions, challenges, and opportunities in making local partnerships more effective and beneficial for all stakeholders. I'll give brief introductions for each of our speakers, but full bios can be found at the event listing on the DGHI website. And before we begin, just a few important notes. You can put questions into the Zoom Q&A at any time during the event. We'll have some time for questions at the end, and we'll be monitoring those questions to get to as many as we can during the conversation. Also, this webinar is being recorded and will be posted publicly after the event for us to access. So now I'm delighted to welcome Dr. Jonathan Sugarman. Dr. Sugarman is a family medicine professor at the University of Washington and senior advisor at Global to Local, a Seattle-based nonprofit whose mission is to advance health equity and improve health in US communities through the application of best practices from around the world. Welcome, Jonathan. I'll leave it to you to take it away.
Great. Well, good afternoon, everyone. It's still morning here in Seattle, but I will start off with a hearty good afternoon to you. Let me also recognize that most of you are participating from North Carolina, which you all know are the ancestral lands of the Shakori, Eno, and Tuscarora people, a region that's now home to at least 8 tribes. I'd like to acknowledge that I'm speaking to you from the traditional land of the Coast Salish people, including the Duwamish, Puyallup, Suquamish, Tulalip, and Muckleshoot Indian nations. I think this acknowledgement is particularly appropriate given the topic of today's conversation, with the recognition of the importance of avoiding some of the colonialism that's been associated with the past and unfortunately even the present of global health, international health, as we try and engage with local communities with good intent and humility, but need to recognize that we're not always doing that with perfect execution. I have no particular disclosures to make. I've received no funding from device pharmaceutical companies or other for-profit entities, but have received or currently receiving funding from some of these foundations. So what I'd like to do over the next 10 or 15 minutes or so is first to briefly introduce Global to Local, which is a nonprofit organization I've been working with for the past couple of years. I'd then like to introduce a framework and some tools and materials we've developed that are specifically focused on assisting organizations and individuals in applying lessons from global health to improve health in the United States. And then I'll share a few reflections on both opportunities and challenges facing those who are striving to apply ideas from global health to improve health and health equity domestically. So as Sumi mentioned, I'm working with an organization called Global to Local. Global to Local has been around since about 2010. It was established by representatives of a number of Seattle-based global health and public health institutions. They recognized that in the Washington state area, there are a number of very prominent global health institutions, ranging from PATH, the Bill and Melinda Gates Foundation, Department of Global Health at another institution, the University of Washington, and began to think that it might be helpful to think about applying lessons from the global health experience of those organizations to improve health and health equity in their local communities. The founders ended up, after kind of doing some examination of local statistical and epidemiologic data, ended up identifying some communities in the southern part of King County, the county in which Seattle is located, in the cities of SeaTac and Tukwila. So if you've ever flown to Seattle, you've flown into SeaTac Airport. When I went to the office in the old days, I could look out my window and see a SeaTac Airport hangar. SeaTac and Tukwila are among the most diverse communities in the United States. There are over 70 languages spoken in the local public schools. It's not a very large area either. Half of the population are not native born in the United States, and an equal proportion of that population speaks a language other than English in their homes. When Global to Local was founded, there was actually a paucity of health and human services organizations in the local community, which in retrospect, in some ways was as much of a challenge to the evolution of Global to Local as it was an opportunity. I'll perhaps talk about that a little bit later. But I will say for now that over the past 10 years, Global to Local has developed and has hosted a number of activities and programs ranging from community health worker programs to assist people in navigating health and human services resources, to community development, to a food innovation network that has established both an incubator program for local food businesses and a farmers market that helps people get access to healthy foods in what was otherwise a food desert. So I'll talk a little bit about that later. So that's Global to Local. Let me first start by just acknowledging that the application of lessons from abroad in the US is certainly not a novel idea. There are many examples of successful adoption of ideas from other countries to address health challenges here in the US. For instance, the birth of the community health center movement in the US was heavily influenced by ideas from South Africa and China, as is, of course, well known to those of you familiar with the work of Jack Geiger in the 1960s as the federally qualified health center program was developed. That said, looking abroad for solutions is not the only, and it's certainly not the primary approach that US implementers take when they're seeking to identify solutions to local challenges. However, some people do find value in looking abroad for ideas that can be applied locally. We recently produced a resource and implementation guide that memorialized some of the learnings from Global to Local's experience over the past decade, as well as the experiences of others throughout the US who've been working to apply lessons from abroad to advance health and health equity here. This work, which was supported by the Commonwealth Fund, relied on the input of an expert panel of implementers from across the country and provided some tools and resources that might be of assistance to healthcare delivery systems and community-based organizations who were considering or at least open to the idea of applying lessons from other countries to meet local challenges. In addition to the framework, which is summarized in this slide, I'm not going to go into it in great detail. The guide includes a self-assessment tool intended to help organizations and entities understand and improve their readiness to apply global learning. It also includes a compendium of activities that organizations can consider as they work to apply lessons from global health. I will say that the primary target audience is actually not experts in global health, as many of you are, but it's rather non-experts who are open to the concept of global learning. As such, it begins with really some rationale about understanding why it might be helpful to look abroad for ideas to improve health and healthcare and health equity in the US, and particularly why it's helpful to look at low and middle income countries for such ideas. You'll understand, of course, that the US does not have a monopoly on great ideas to address healthcare challenges, and that creative solutions in other countries, including those with far fewer resources, have yielded outcomes that, as Sumi alluded to it in the introduction, really outcomes of which the US could be very envious. So the framework really starts with a rationale of why, and there's a bunch of kind of background material there. But the second piece of it is a little bit of thought about how global ideas can contribute to improving health and health equity here. And we think that there are several different ways there. They overlap in some ways, and a single idea or project can be both inspiring, an example of a strategy or of a specific program or tactic. But let me spend just a second to show you some examples of what I'm talking about. So Many people, when they think of application of ideas from global health locally, think of transferring, either adopting or adapting in some way, a specific program or tactic that was initially used in another country. So one example of that might be the Friendship Pitch, which was a program that was developed by a psychiatrist in Zimbabwe named Dr. Dixon Chibanda. Dr. Chibanda was responding to the fact that there were only 10 psychiatrists serving a population of 13 million people, and very few behavioral health services in primary care. So he trained a cohort of lay community members, most of them actually were local grandmothers, to understand, diagnose depression and related conditions, and to learn about and then to administer really some basic problem-solving therapy through some brief interventions. Several years ago, Dr. Mary Bassett, who at the time was New York's Commissioner of Health and Mental Hygiene, who had worked in Zimbabwe, is familiar with that approach, worked with Dr. Chibanda to bring that Friendship Bench approach to New York City, where it was adapted somewhat and implemented in various neighborhoods by trained peer counselors. So there are many examples of similar transfer of specific programs to the United States, and a number of them are summarized in the document that I just showed you. A second way in which global learning can contribute to domestic efforts is to identify general strategies or approaches that have been adapted or used in other countries. So an example of such a strategy would be the use of community health workers. You're all familiar with the organization Partners in Health, and they have adopted an accompaniment model of community health worker implementation that was initially developed in Haiti, Rwanda, and Peru, and other countries, to be applied in the US. So the PACT program was a program they had in Boston to assist people with medication adherence, healthcare navigation, access to behavioral health services for people with HIV/AIDS in Boston. So what do I mean by strategies? Early in Global to Local's history, it commissioned PATH, a global health organization, to conduct a landscape assessment of global health strategies that were potentially transferable to the US. It was first done in 2010, updated in 2017. They ended up identifying 11 strategies, 7 of which are shown in this slide. Now, clearly, none of these strategies are unique to other countries, but the emphasis that that's often placed upon them and the specific ways in which those strategies are prioritized really can be instructive to American audiences who are striving to overcome various challenges to public health and healthcare delivery. So throughout its history, Global to Local has used this list as kind of a checklist when confronting problems to say, are there ways in which these strategies have been used in other countries that could be adopted or modified to address problems here. And you'll see a link at the bottom of the page if you want to get some more information about the strategies and how they've been implemented elsewhere. The final way in which we think that those ideas from global learning can contribute is really that neither a specific program nor strategy, but really general inspiration. So in some cases, exposure to examples of how other countries have worked to improve health can inspire people to conceive and implement creative solutions to local problems, even if they are not exactly the same and if the environments are really quite different. So for example, since 2005, the Community Partnership for Health Equity, which is a program of an Oakland-based nonprofit called MEDIC, has facilitated visits to Cuba from leaders from low-resource US communities. The purpose of the visits really has been to stimulate critical thinking in order to identify creative solutions to local concerns, rather than to encourage adoption of specific Cuban health programs. Obviously, the Cuban context is considerably different from the US, and many of those differences pose challenges for transferring specific interventions. Nevertheless, these visits have really inspired participants to launch a variety of health promotion, disease prevention, and primary care public health integration programs. As an example, several years ago, a delegation from New Mexico visited Havana on a MEDIC-sponsored trip, and they visited the neighborhood consultorios. So those are clinics that are staffed by nurses and physicians who live within the communities that are being served. The visitors from Albuquerque were really impressed about the deep connection between the providers and the community they served. After returning home, they tried to think of ways to emulate that. Now, those ways were not to have the health centers providers necessarily live in those communities. Instead, what they did was start a weekly walking group in which doctors, nurses, social workers, and others joined community residents for hour-long walks around the neighborhoods surrounding the clinics. And in that way, really kind of emulated or were able to, in some way, gain a deeper understanding about the difficulties that people faced in the community as opposed to those that they saw just in the clinic. And in doing so, we're able to really develop programs that were more appropriate for and met the needs of the local communities. So Global to Local, it turns out, has really focused on being inspired by lessons from global health. Some of you may have noticed that the title of the resource guide that I showed earlier on referred to improvement of primary health care. So that's different from primary care, first contact, continuous, comprehensive, coordinated healthcare delivery. That's one of the three major components of primary healthcare, as defined by World Health Organization and memorialized in the Alma-Ata and Almaty declarations. But the other two components are equally important. Those are multi-sectoral collaboration between civil society, government, and the healthcare industry and communities. But the third pillar is really a focus on community empowerment and community engagement. And therein lies, I think, one of the most fertile areas of potential collaboration and learning for those of us in the US who want to advance healthcare using ideas from across the country. So let me just give you an example of how Global to Local started. As I said, it started with a bunch of public health and global health experts. They went down a well-trod path used by us academics by identifying problems by looking at epidemiologic data. Long story short, they identified in this community that there were much lower immunization rates than in the rest of the county. And came to the community and said, gee, we think we know some things about improving immunization rates in other countries. We could help here. And the community was like, not so crazy about that. So what the founders of Global to Local started off with was a needs assessment based on what's often called normative needs. And there's a reference at the bottom of the slide if you want to learn a little bit more about that. So those are typically standards or targets established or developed by professionals like us. As opposed to felt needs, needs based on what people in communities say they want that are informed by lived experience rather than by data collected or analyzed by some third party. So the Global to Local founders reached out to community stakeholders to explore opportunities. They actually spent about a year asking the question, what makes it hard to be healthy here? Community members highlighted things such as limited economic opportunity, language and cultural barriers, difficulty navigating the healthcare system, and particularly limited community voices and decision-making at various important civic and other tables. So that was actually what was the driving force for development of many Global to Local programs, one of which I've shown here on this slide, which is a program of our Food Innovation Network. And in order to kind of address some of the needs developed by the community, both for economic empowerment and availability of healthy foods and otherwise food desert, first they started a community or garden. Often there were immigrants who had food preferences that weren't necessarily met by the locally available food. So they started this food farmers markets, but also started an incubator program for businesses, which just last year culminated in the opening of Spice Bridge, which is a global food hall, which now hosts 13 businesses, most of which are owned and operated by immigrant women. I think there are 1 or 2 men who are owners of these businesses. That's been a huge boon to the community. And all that came from the engagement of the community to help them identify what they thought community needs are. And in fact, now, Global to Local has also been working on COVID and other immunizations, and because of the engagement of the community, has been very successful in providing immunizations, what the founders of Global to Local first started thinking about because of the trust that was developed over many years. time is short. I'm afraid I may have already worn out my welcome and gone through my time constraints. So I'll stop there with the hope that at least some of what I presented can be of use to you at the Duke, as the Duke Global Health community seeks to increase its engagement with the community in order to advance health and health equity and healthcare locally. So with that, I will stop sharing and turn this back over to Sumi.
Thank you, Jonathan. That was great. A really helpful overview of work in this space and things that are going on around the country and some history. Thank you so much. I'm going to now give some brief introductions to all the panelists, and then we'll go to our discussion. And again, full bios can be found at the event listing on the DGHI website. So first, Deborah Clark-Jones. I'd like to introduce her. Deborah is the Associate Vice President for Community Health at Duke Health, where she works to bring together Duke's role as a university, an employer, and a healthcare provider to better support communities holistically throughout the state. Karen Kelly is the Chief Program Officer at TROSA, the Triangle Residential Options for Substance Abusers program, where she's responsible for the complex day-to-day operations that provide services for over 400 men and women in recovery. Dr. Deepak Kumar is director of the Julius L. Chambers Biomedical Biotechnology Research Institute at North Carolina Central University, where he provides leadership for a broad research portfolio that includes cancer, cardiometabolic disorders, neuroscience, and nutrition. And Dr. Catherine Wetton. Dr. Wetton is a professor of public policy and global health here at Duke, with additional appointments in community and family medicine and nursing. She's also the director of the Center for Health Policy and Inequalities Research, which is part of Duke's Global Health Institute. Welcome to you all. So we're going to start with asking each of our panelists a question related to their work in this local and global workspace. And I'll start with Kate. Kate, you worked on a number of local to global projects over the years. Can you talk a little bit about some of the projects that you've had that have been able to create the kind of bilateral application that Dr. Sugarman was talking about? And also we have a question in our Q&A around some of the common challenges when it comes to applying cultural traditions and differences from global programs to local settings. So I know, Kate, you work a lot in that area as well. So if there's anything you can share around that, that would be wonderful.
Okay, thank you. Thank you so much for hosting this and for having us here today. And yeah, global to local, I think, has been happening for a long time without our even recognizing it. As an example, community-based participatory research really actually grew out of communities in Latin America and on the continent of Africa in different places, and actually started appearing in the 1920s, but was only formally recognized in the 1940s when some folks in Latin America started working with an American who started publishing on community-based participatory research. So there's a long tradition of learning from other countries that's already there. In my own work, I was a public health practitioner in what was Zaire, now the Democratic Republic of the Congo. And one of the things we were doing in the beginning of the HIV epidemic was working with communities, and communities were doing asset mapping, involving churches, involving leaders in a way that I hadn't really seen here in the US. And when I came back and got my master's degree and then PhD, really wasn't taught to have that kind of community input in and participation in the work that we were doing. When I wrote my first grant in 1996, a long time ago, we brought together 54 counties across the eastern half of North Carolina to work on HIV prevention and access to care, getting into care, and why people may or may not trust the care that they receive. And the similarities that we found between where I was in the DRC and in the eastern half of North Carolina were quite striking. And so the models that we actually put in place back at that time were based on what we'd learned in working with community health volunteers and working with community organizations, grassroots organizations, and really enhancing the participation of community members. At that time, people did not really want to hear that the model that we actually put in place over a 5-year period was based on something that was in Central Africa. But what became clear with the HIV epidemic generally in the Deep South in the studies as we continued was that there was more similarity with other low and middle income countries than with other areas in the US, such as California and New York, and places where people had been modeling what we should do for HIV care. As we continued, we found that substance abuse, that childhood trauma was really important in predicting high risk behaviors, high risk for HIV. And we developed a model of care that included substance abuse and mental health services. Some colleagues from Russia said, gosh, could we adapt that for women who are new moms here in St. Petersburg, Russia, and see if we can help them with substance abuse issues and lowering their risk for HIV. As we implemented that program, it became clear that the moms needed to have caregiving for their kids, which we had tried in the US but couldn't do because of liability. So they set up a kind of a care schedule for the kids, or not scheduled, but they cared for the kids separately from the women. There was about 50% no-show rate for women coming to their appointments. And at the same time, the woman who was working with the kids was a counselor and realized that the kids were suffering from trauma, anxiety, depression. And so she started implementing a program where she was getting the kids to draw out what they were feeling, and then would bring the moms in at the end of the sessions, and the moms would work with the kids, and they would start talking with each other and talking about parenting. Then the moms started requesting to talk to a pediatrician once. They got to choose a session once a month. This is something that, again, we couldn't have done in the US because there was abuse happening in the families. And the model in the US is that we take the kids away while mom is supposed to get substance abuse treatment, but then she can't get in. There are long waiting lines. There are different things happening. Lots of anxiety because the kid isn't there. So we brought that back to Durham, and we're able to get a judge in Durham to say, okay, I'm willing to test this. I'm willing to give this a try. If you can promise that these women are staying in care and that the kids aren't being abused now, then let's see if we can test this. So really neat bilateral. And then also, and I'll conclude with this, going back to Tanzania, we found that trauma was the biggest predictor of kind of the sequela that led to HIV. We then took that to Tanzania, and I can say our colleagues said, you are not going to find the same thing. You know, you've got the two stereotypes of people living in different African countries, of the kumbaya and then the very hostile. And sure enough, we found that it was actually childhood trauma that was most predictive of high-risk behaviors, of getting into care, of trusting care, really similar kind of results. And so we were able to change care systems as we did here in the US. So those are just some examples. I could go on. We have an orphan model we've also adopted, but I'll stop there.
Great, Kate, thank you so much. That was so interesting. And I think we could have a whole panel or a series of discussions just on some of these types of examples that you and others have worked on. We are really fortunate to have our panelist, Dr. Wanda Boone, join us. So I'd like to introduce her real quick. Hi there. Hi, Dr. Boone. Nice to see you. So Dr. Boone is the founding director of Together for Resilient Youth, or TRI. It's a coalition of Durham-based community organizations working collectively to address underlying root causes that set the conditions for many health and societal problems, such as substance abuse, crime, and violence. And if it's okay, Wanda, I would like to go to you next for a question.
Mm-hmm. It's fine.
Great. So Kate talked about examples that put a lot of effort into partnering carefully, increasing trust, and understanding solutions that could work in local contexts. And you've worked, I know, with a number of Duke researchers on projects in the local community. From your perspective, what else needs to be done, or how else can we work to increase the value of these projects to community partners, especially the end clients?
Mm-hmm. Thank you for your question, and it's good to be here. So there are a lot of things that I could say. I think that my experience might be a little bit different than others, but it's why I am comfortable communicating in this space of community members, community-based organizations, and researchers. And without taking a whole lot of time in that, I will say that I began this journey in the 70s, and I'm going to go really quickly through those, with Dr. Charles Rowe, a physician at Duke back then who did research on myocardial infarction. And so I was the research specialist with him. And then later in the 80s, he did research on babies that were born with metabolic disorders. And so I was able not only to do some of the innovative testing that he actually was the origin of, but I got to meet with families and children, and that human connection was really important to me then. In the early 2000s and later on, I worked with Sarah Weaver, and we co-authored, I guess you will describe it that way, something that's called Small Bites that's still being used at Duke. It's probably in the archives. And it's kind of a way to acclimate medical students to what's happening in the community. And so there are 10 modules. And so, I'm thinking, how to apply this with the work that we're doing. And then Sherman James, who was absolutely phenomenal in terms of what he did, community participatory research as it pertains to diabetes, and creating a model where people helped themselves with researchers kind of taking a back seat, not as visible, but still very important, of course, in the process. And so that was absolutely wonderful. And so now our research, or the things that we've discovered as a community-based organization, really has to do with what Kate was talking about. Starting in 2014, looking at adverse experiences, not only childhood experiences, but climate, community, and atrocious cultural experiences that influence the work today. So that long story longer, what I can suggest is to trust the community in terms of being able to understand and participate as co-equal partners in research. I cannot stress that enough. There's been so much distrust in terms of how research might have been perceived or used in the past, until, I see myself being a bridge builder to say, no, it's not that way anymore. But sometimes it still is that way. So yeah, that's what I would say. That would be the most important thing. And then we have community health workers who, people like to see me coming, but they really like to see community health workers coming because they live in the areas that they are working in. That was long. I apologize.
No, that's great. Thank you. Yeah, thank you. And I know you alluded to the idea of having community partners and researchers really be co-producers, co-owners, co-developers of the process. And maybe we can circle back around to some of the barriers or challenges in doing that. But Deborah, I know that you talk with your team a lot about some of the guiding principles for Duke engagement in the local community. And one of those is ensuring that the relationships with community partners are sustainable and equitable. That we try and strive to do the things that Kate, Wanda, Jonathan, and others are highlighting. Could you talk a little bit about, from the university perspective, what are some of the challenges you see in these areas that researchers should be aware of or can do differently?
Absolutely. Thank you, Sumi. And I feel like I'm going to echo what everyone else just said. And I think that it's clear that we can't just helicopter into a community and start the research. And so when we talk about equitable relationships, we're talking about equity and benefit, equity and power sharing and decision making, alignment with the priorities of the research and the community's priorities. So building equitable relationships, it's a worthwhile investment, but it requires a willingness to listen, willingness to reflect on what we're hearing, And also the ability to build empathy with community members. So the first challenge that I would cite is that not everyone is good at that, right? Not everyone can do that intuitively. And so you've already mentioned the fact that it's really important that we establish a shared set of principles around community engagement. And that should really be established throughout the entire organization. It's something that we should all subscribe to and align with. We should also, of course, look at training and consultation. And I'll do a quick plug for Duke's Office of Durham and Community Affairs. They do a lot of work around community engagement, provide training and consultation. Leslie Parkin's group, as well as Mamie Webb Bledsoe's group with neighborhood partnerships. So learning about those best practices and even the global to local examples that Jonathan mentioned, I think that there's a lot to be gleaned from that. And then codifying those principles, hopefully in the form of toolkits, and the like, I believe is really important. Wanda touched on the importance and the impact of community health workers. I also want to make a plug for the diversity of the research team itself, particularly when it comes to the inclusion of those with shared experiences with the community that that researchers are seeking to work with. I think that is critically important. The level of understanding the problem. Too often we want to jump in and just apply a solution thinking that we already know what the community needs. And so Jonathan also spoke to the fact that global to local, at least in one project or on one project, they spent an entire year just around engagement. So taking the time to really understand the social, environmental, economic, historical context. And Wanda also alluded to that too, as it relates to the harm that's been done. I think that we also have to be mindful of our reputation and the historical experiences that community has had with our organizations, and make sure that we're not causing new harm by following through with the commitments that we make to community, and making sure that we follow up even after the project concludes. I think that a lot of community members have felt quickly neglected after a project has concluded. And then lastly, and this is just around sustainability, the importance of community ownership, and that is normally born out of those equitable relationships that we encourage all researchers to form in order to sustain those solutions in the community as well.
Great. Thank you so much, Deborah. And, you know, there's a lot to be said, I think, also in terms of thinking about applying a lot of the principles you're discussing in terms of how we as researchers really structure the mandate of our work, right? And the mandate of how funding is put into place, and the short-term versus long-term sustainability of that, and including community partners. I think that's where some of the challenges are. I think we all agree with these issues, and you've highlighted them so nicely. It would be great to really talk about what are some of the stumbling blocks in doing it. Kind of circling back around to that at some point too. And Karen, I wanted to come to you. You work with one of the more unique and recognized community organizations in Durham, but you've also been an academic researcher at UNC, and basically sharing some of the highlights and insights that Deborah was talking about. From your perspective, what are some of the challenges you've seen in your role? And especially, are universities doing enough to protect the rights and interests of not just research participants when they partner with NGOs, but also the rights of communities? Can you tell us a little bit about issues in that space?
Sure, yeah, thanks for having me here. It's great to be here. And I'm going to echo a lot of the same sort of sentiment that I'm already hearing, but maybe a little bit of a unique spin. So I think as researchers, people spend a lot of time thinking about the negative effects that could be given to an individual. You know, we have IRBs in place, and we make sure that there's informed consent, and we make sure that people really understand the risks and benefits of participation. And I don't know that we spend a lot of time thinking about the risks and benefits to the entire community. So as an example, imagine you're working on a syphilis treatment, and your research community is an indigenous community. And when you publish, you talk about this great new treatment you have, and you describe in your paper that the research took place in this community where syphilis rates are really high. And then the news picks it up, and the word gets out that what the news is talking about in part is that the syphilis rates in this community are really high. And this community generates a lot of its income through tourism. And now people aren't coming to that community as much because they have these negative stereotypes about people who contracted syphilis. It's not on anyone's radar at the beginning of that project that they might really undermine the economic stability of this community. I'm sure the researchers that went in to do this project had nothing but good intentions for the people in this community, but as a result, there was a big erosion of the economic stability of this community. And there's, environmental health researchers where the individuals are protected. They participated in hog research, the health effects of hog research. People don't know what people, but they find out what community, and now the plant leaves the community. So I just think it's important for us to think about individual impacts, but also what are the community impacts of research, and how do we make sure that the community does some sort of informed consent. So that's one piece to talk about. And I think the other piece to talk about is that often we can have shared goals around improving an outcome or improving the health of a community. But the community often, I'll just speak for TROSA, we care about the process, and we care about sustainability, and we're very process oriented. And in my experience, often, understandably, researchers are focused on product. There's a huge emphasis put on publication. And often I have found that we hit some roadblocks as far as not authorship, but actual power of how our community is described, what gets published, and how it gets published. And I totally understand and honor the desire to be able to publish results that don't look good for the community. If it's going to be helpful and it is the truth, we don't want to hide that. And also, we need to think about the implications to the community for publishing some, certain information.
Yeah. Thank you. Those are, provide a lot of food for thought. Karen, thanks a lot. Dr. Kumar, if I can come to you now, as a researcher and professor at a university closely tied to the local community, are there lessons your group can share that help address some of the challenges that Karen just talked about, Wanda, Kate, and others, Deborah, have discussed? And also, what are systems you've seen at NCCU that you think other universities can follow to improve work with local partners? Are there any lessons to be shared there?
Thank you, Sumi, and I'm very happy to be here. I think I'm going to echo a lot of what has been already said, so I don't know there's a lot which I can add to, but I'll just say that as Deborah, you alluded to, that it all starts with empathy. There has to be a need to do much more than just equity tourism. We have researchers who want to do health disparities research, equity research, but it has to be more than that. And you talk about, so it has to start with empathy. You have to do more than equity tourism. And also you need to you need to have researchers. You have to have diverse researchers who can connect a little bit more than just an academic exercise. It has to be more than that. I think that's why if you really want to make a difference in health disparities research, equity research, as I've said several times, that we must cultivate researchers of color and diversify the biomedical and equity workforce. Otherwise, I mean, we make a dent here or there, but we will not be able to make a real difference unless we have a diverse workforce and diversified researchers. And that's why HBCUs, that's where HBCUs come into play and the systems that you talked about. I mean, we are in the community. It's not that we don't make an effort in the community where you have a problem, because we're already there. So I think being in the community is a strength that NCCU brings to the table. A lot has been said about the principles, but I will give you an example of COVID. I mean, that has really exacerbated disparities and and the equity issues so much. I mean, look around. I mean, we are year and a half, with the vaccine, almost a year with the vaccine, and we are still at about 32% in some counties. And what are those counties? I mean, you can really look at the demographic and see, and you can really relate to the trust and whatever we talked about right now. We have done so much work globally, as Jonathan will attest to, in terms of vaccination, and we are still at that dismal rate in some of the counties, and a lot of work that has been done. So and we were there, our systems were in place. We were not able to do a whole lot, as just like everybody else. But when COVID started, we were surprised, and several of reports were like very surprising that why there are disparities. But we knew this all along, that the underlying conditions, the disparities are not new. We talk about social distancing, but we knew it all along about the multi-generational households, the housing problem. I mean, why were we surprised? We should have been a bit more prepared. And that brings to the point of resiliency. I mean, it should not be reactive. I mean, we have to build resiliency in the communities while we can. I mean, we don't have to wait for pandemic or any other chronic disease, to start. I mean, so I think community resiliency is something that we must. And what we have been doing very little work, and I'm sure organizations over here, I mean, Duke UNC and many others, and Trosha and others have done phenomenal work in the community. But I think there has to be more effort in building resiliency in the community. So when these things come, we are prepared, or at least we have systems already in place in the community. We cannot just go as saviors to go and do things in the community. And I think that's where we were able to make a very small dent in the first testing effort, and the second, when the vaccination effort. So before the vaccine came, we wanted to make sure that we get the voices of people. And I'll give you an example. We started collecting surveys about vaccine hesitancy way before the vaccine was introduced, and we used paper and pencil, because our philosophy was that you cannot really use the means that people don't have to collect the data. And we knew about the digital divide, and there were all these panel surveys that were going around. And while it is okay, and results may be similar, but again, you don't want to exclude people from giving an opinion just by not having those tools. So we wanted to collect that data. But what we also did was then we reached out to people. I mean, we have partnership with Duke CTSI. I do want to put a plug in there, with that. I mean, Ebony Bulwer has done a phenomenal work, not only in terms of community engagement, but building equity piece into the fabric of CTSI. And that institutionalization is so important to put in. So we partnered with them, and we have done some work, but we took this data back to the community, going back to what has been said before, that community wants to listen. Okay, so you were here, you collected all this data, but more than often, we don't go back to them and share the data with them. And I think that's very important. And what we did was we used that sharing of the data to create a narrative around debunking some of the myths around vaccine hesitancy. So we got something out of that for us also, but we also satisfied the community that this is a co-creating process together, that how we are going to solve the issues. So I think those are some of the things that we were able to do. But then you don't stop there. You reach out to who can make a difference. I mean, for example, the vaccine. We were not distributing the vaccine. All the vaccines are controlled by state. So we reached out to them that, look, you know what, here is the data. We are going to give you the data, now do something with it. And then, so we formed a partnership with the state so that they devised plans about the transportation issues, incentives issues, and we engaged them. And they reached out to us that, look, you know what, we have an incentive plan. We are planning the incentives. Can you help in evaluating that piece? And we evaluated that piece again, because we were able to go back to the communities, and community members knew because we were there when the pandemic happened, before the vaccination piece. So again, building these relationships early is the key. Being there is the key. You don't go there when you have a research project. You don't go there to collect the samples. You have to have that. Very recently, again, from global to local, we have acquired a mobile health unit. And we are getting, we have one, and we are getting one more. So the 2 mobile health unit, the whole idea is taking the care to the community. And when you do that, you are also creating a very large core facility for the researchers here, which is available, who is already doing the work in the community. So you already have that system in place who can, assist the researchers in doing these CBPRs or whatever you want to call those research in a much more meaningful way. One other piece I do want to make sure to mention is that you also want to expose the researchers to the community. A lot of times researchers, they don't have a lot of field experience. They don't really know the local problems. I mean, we write the grants and we read the papers together, and we have community navigators, patient navigators, and community health educators, and they go and do all the work. But I don't know how many times the PIs themselves have been exposed to what is going on in the community and the problems that they have. So I think that kind of exposure is also very important for the researchers. Well, just like everybody else, I can go on and on, so I'm going to stop here.
Oops, I was muted. Thank you so much, Dr. Kumar. Jonathan, if you are able to circle back in, and I'd love to bring it back around. First, if you have any reactions or thoughts from what you've heard that you would want to share, we could start with that, but otherwise I'll ask you a question.
Okay, so my reaction is it's validating to hear the consistency both among you and between the concepts that we've kind of endorsed in terms of, first, the importance of community engagement, because each of you addressed that in some way. The importance of kind of humility as an outsider, as Dr. Kumar just described very articulately, the issues of PIs not necessarily being on the ground and understanding the needs of the community. So all this is very helpful. I do think that in the context of kind of learning from global experience, there are a number of resources, I'm certain within your institute, but for instance, Renee Lowenson recently published some work under the auspices of the Training and Research Support Center. I think it was Robert Johnson funded work, where she looked at community participation in health in 13 countries, and then came out with some principles. If you look at the document that I kind of included, there's a reference to that. But as we talked about earlier, none of these are uniquely global, but the ways in which they are implemented, as Dr. Wetton described, really differ sometimes in emphasis and priority than we see here. So I was very interested to hear Kate's description of her experience. Another thing I'll just say resonated was, I think you mentioned, Kate, maybe I misunderstood this, that people weren't necessarily happy to hear that the model came from a lower income country. We actually found something similar, that if you start off particularly in a vulnerable, marginalized community and say, hey, we're bringing you something from another vulnerable, marginalized community, instead of focusing on community assets, to focus on deficits is potentially problematic. So that's one thing that was kind of embedded in what Kate said that I think is also very consistent with what we heard. People were not necessarily interested in looking to East Africa for solutions if they didn't see their own community as connected or associated with that, even if the principles were something that was easily transportable. So those are my initial observations, Sumi.
Great, thank you. There are so many different angles we can.
Can I
Yeah.
just add to that for a second?
Yeah.
I think that's really interesting, Jonathan. And what's interesting is that has very much changed over the last 5 years. And I think as we've thought about our kind of the racial awakening amongst European descendant folks and the visibility, there's actually much more acceptance saying, no, I actually want to learn from people who are doing this, who've modified in another, we have trauma-focused cognitive behavioral therapy. They've totally modified in Kenya in a way that would be brilliant in communities, particularly communities of color here. So that narrative has really changed from, oh, well, we can't learn from, please don't put us in that position, to, no, this is really about assets. This is about what we can do really well. That's interesting, yeah.
Yeah, and Wanda, I know you've done some work recently with researchers here at Duke, exactly applying that model from Kenya back with TRI, your organization. Is there, I know there are lots of things that are going really well. Is there any lesson or steps forward that you can share that we should all be thinking about in terms of what are stumbling blocks or pieces that we can look out for?
Yes, so Dr. Eve Puffer brought Coping Together, a family communication model, resilience-based model from Kenya to Durham and found TRI. The program was already written. There were some nuances that needed to be worked out for cultural reasons, but the humility that she and her team displayed in hearing what we as African Americans here in Durham, North Carolina, had to say, no, you can't use that picture. Yeah, I mean, you may think it's a good idea, but no, you can't use that picture. Don't use this phrase. And so we co-developed the curriculum and are included as a part of the authorship. So, you know, I mean, so that really is remarkable. There were some, you know, people that had some issues, but she was the boss, so we won.
And Sumi, if I could just add very quickly to that, because I am glad that things have changed in terms of the acceptance of other models from other countries. I think that I do want to double down on this asset versus deficit perspective and just how important it is, because I think it's also reflected in a lot of the materials, as Dr. Boone just mentioned too. We're talking about empathy, not sympathy. Right. And it's really important to respect the insights, the knowledge that exist within the communities, and really tap into those assets as we look to solutions for different issues.
Great. Thank you. Well, this has been really great. Thank you all for all of those insights. And unfortunately, it looks like we're out of time. So we'll have to leave it there for today. But it's clear from the conversation that all of the types of insights and experiences you've shared can spur critical ideas for all of us. And then there's a lot more work to think through and discuss. As we've talked about, one important question for many of us is whether research, interventions, and approaches to addressing structural inequalities and ill health in other countries could also work in local communities here in the United States, and a lot of great examples of how that's done. But our hope is that we can build on this discussion to continue understanding how best to increase transparency and trust, and structure the development of partnerships so that the lessons learned are more equally co-developed, co-owned, and the benefits more equally shared. And really, what are the barriers to doing that? I think we're all in agreement that they need to be done and some of the best practices and how to do it. And I think the next step is really to think about what are the roadblocks in place that we can all look out for. I want to thank all of our speakers for taking the time to share your work and perspectives. This webinar has been recorded and will be posted to the DGHI YouTube's channel in a few days, and please feel free to share it with others who couldn't make it. Thank you again for everyone and for your time to participate.
Thank you.
Thank you.
Thanks.
Thank you.